Sir, should we start, sir?
Yeah, I'm ready.
Yeah, please proceed.
Yeah, good. Hello, participants. I hope we can start now.
Yes, sir.
Yes,
Yes,
Professor,
sir.
yes.
Oh, sure. Okay.
Yes,
Fine. So just a minute, I'd like to review. We started with health informatics, its definition, its tentacles, under umbrella, what are all the various types of informatics. And I have defined medical informatics as an ICT application in individual. Bioinformatics is an ICT application for a molecule. And under medical informatics, as per definition of Van Bemmel, I have given a definition. And the 6 layers: communication, data acquisition, storage, retrieval, automation, processing. Then you have a decision-making process, diagnosis, therapy, and then research and modeling. All those things I've explained. What are the basic building blocks of health informatics? Then public health informatics, all those things, clinical, all the definitions I have introduced to you. Kindly learn further. They're all beautiful topics. And then what impact this health informatics would have on the whole world in general and India in particular. And after traversing through this impact, now we are in the final stage, how to really reach there? What's the way forward? As I told you, the way forward is every one of us, all of us are stakeholders. Everyone has to put our hand and mind and work towards it. However, it's a top-down approach. And I said that, yes, way forward is first adopt the international standards, as simple as that. Whenever you want to be, the top 3 of the world or top of the world, then you have to understand the standards. You have to give respect to standards across the world. Yeah, WHO and the people have given some standards, which is rightly so adopted by NDA, National Digital Health Mission, and whatever the colored centers have given talks about digital health. There are a lot of things, but digital health is very important. And you can see the point 9 to promote clinical decision systems, which is nothing but our layer 4. Therapy and control is layer 5. So if you see this carefully, all the 6 layers are embedded in this. And I told you that, yes, India is not at all lagging behind in IT. Please understand. Computer science IT is adopted by majority of the Indians. Even the poorest of the poor knows what is IT. But what is unfortunately is not there is IT has not penetrated into healthcare. So I think it's time that we have to do it. That's why I gave the statistics. 15.76 lakh crore digital transactions are happening in India, but unfortunately 2% is in healthcare, whereas 95% in the USA. I think this is just a glimpse. Why I'm giving this is we have a long way to go. And National Health Mission has been formed. This is a way forward. These are the people who will be taking India to the next level and will be working along with the top hierarchy. And the vision is no doubt ensure health for all. And these are the components: health system engineering, non-communicable diseases. There are certain objectives and vision of each and every body that Government of India develops. You have ABDM components, Ayushman Bharat Digital Mission. ABA number is very important. And today, if you see carefully, there are 71 crore ABA registrations. You can see wonderful statistics. ABA numbers are 71 crore. ABA linked health records are 46. Healthcare facilities, hospitals, laboratories. There are 354 hospitals and healthcare centers are there. Professionals, yes, doctors. Registered doctors are 541. Not that this is not the final picture, but this is a registered picture. The actual data is much beyond that. Active integrators. This is some data, the way forward. Yes, health informatics. Yes, this is a website of CDAC I have taken. You can visit the website of CDAC, right? To put the, term as hospitals, you'll get. Also go to NIC, National Informatics Center. They're doing a really work in this medical informatics and healthcare informatics. So hospital information system, drug management system, healthcare standards, mobile health application, decision support system, telemedicine solutions. So these are the area which CDAC has taken up. They're doing a wonderful job. Their packages are available. And our job as a faculty is to see that these are introduced to our students, because these people should not think India is doing nothing. We are doing, but without us, there is no India. So we have to be part of this change. Then e-Sanjeevani, then you have salient features of this beneficiaries, then CDAC, health information system, hospital. These are all cut and paste from CDAC website for your kind information. Kindly go through it, visit and click and go through the menu. I really will appreciate. And these are all the, you have patient registration, billing. So whatever we have been discussing in the last 1 hour are all available there, but in bits and pieces, not in as a whole. You can see here, radiological information system, RIS, laboratory information system, hospital information system, inventory, laundry. These are all components of a very good medical informatics and health informatics system. ADT, admission, discharge, and transfer. They're all there. No doubt. The organs of the government has taken up, but we have much more role to play. Without us, there is no government. As citizens of India, as a citizen who has real knowledge, we should not lag behind. We have to support our government to see that, yes, healthcare is becoming one of the biggest one in India, and national health apps are being the Arogya Setu. A lot of people have registered.
Sorry to interrupt, sir.
Yeah.
Hello, sir. Sir, your screen is not visible right now.
Oh,
can
my
you please
goodness.
reshare?
Okay. Is it visible now? Share.
Yes, sir, it is visible now.
Okay, I'll just nothing. I'll just
Yes, sir.
No problem. It's a minute. Nothing. So, National Health Mission components, ABDM components, HABA number, and the registered 71 crore, etc., all the statistics. These are all available in the website of the ABDM sandbox model. They encourage. See, they have given some standards, and my humble request to all of you is that whatever healthcare system software that you develop, check that you are incompatible with the recommendations of sandbox integration. This is very important. This is what I'm using it. ABDM has come out with a recommendation that anybody can contribute to the development of healthcare informatics system in India. However, they have to meet all the standards. So you have to prove to them that your software meets the standard. Therefore, from the day one, whatever software you develop, just don't develop off the record. Just a layman, please understand the standards that I have shown you, right? Please think about it and do it. And this is the website of the CDAC and NIC and ABDM, National Health Mission. All of in bits and pieces, I have brought it for your kind information. But you can go. You have this is the the telemedicine that has been done by CDAC, e-Sanjeevani. Then you have the salient features of it. CDAC Health Informatics. You have this is what I was explaining: hospital information system, laboratory information system. RIS means radiological information system. PACS is there. EMR, electronic medical record. Health. See, there are 3 terms: patient medical record, electronic medical record, health medical. All are 3 are different. Kindly go through the definition. So billing. So all this put together is health informatics. National health apps are there. Then yes, EHR platform. Yes, I think I have come to an end. Imagination is more important than knowledge. See, I wish that every one of us has to move from knowledgeable person to a wise person. Is that you understand? Jnana, wisdom is important than knowledge. So the best way to become a jnani, a wise person, is to become a child, nothing else, because a child can think diagrammatically opposite than what is normally available. And it has more imagination. Unlike us, we have limited imagination because we are grown-ups. That is not good. We may be grown up, but when we are mentally open-minded, I think wonderful ideas would come to you. Don't be discouraged. Be happy. Excitement is just beginning. Technology will not be our limitation. We are limited by our own imaginations. So we are limited by nothing. We are not. The only thing is we are not resourceful. With whatever we have, yes, we can do it. Yes, anyhow, we have to meet our challenges. See, nothing comes as simple as you like. When you take up a job, these are mission, task. You will be landing and a lot of crocodiles. These crocodiles are nothing but challenges. So you cannot have something with no challenge. Everything will be resisted. But you have to live. You have to fight with these challenges and win. Okay, discussion, anything that we'll see. Or is a gate country, Varanasi, Western Thought, God's own country, temples. Okay, I think I have completed my first part. And the second one is AI in dentistry. I'll take it up with your permission. Can I close this? If you have any doubts in health informatics, kindly. I'll give some 5 minutes. If you have any doubts, I'll clarify. Otherwise, I'll go to the next topic.
Excuse me, sir.
Yeah. Please.
Myself, I am Harsha from Kerala.
Fine. Welcome. Good evening.
Sir, if you are okay, sir, if you are producing a software or we are making a electronic device for medical application.
Yeah.
So before launching that, we have to take these standards, no? From where we are, how we should proceed actually.
Well, it's very simple. Your name is good name?
Harsha.
Harsha. Your Harsha is very simple. First, you refer the standard called 62304. IEC 62304, which is software standard. Okay. They might have given you how to develop a software. That's the first step. Next is the risk analysis. That means if your software fails, will it really hurt a patient? Will it kill a patient or will it hurt a patient? That is again define your software as class A, class B, class C based on your risk. Understand?
Okay, sir.
And
okay,
then whatever software you develop should have interoperability, which is nothing but you have to follow FHIR standard. FHIR.
FHIR, okay.
Yes, FHIR.
Yes, sir.
Yeah. So these are the three important things. And also, whenever you are writing a software, don't give your own terms. Tuberculosis, myocardial infarction. They may not be the standard words as per WHO, ICD-11, International Codification of Diseases. You have to check whether any medical device you are naming is in consonance with the WHO standard ICD-11, or you have to check SNOMED CT. Systemized nomenclature is given. So whatever you refer should be under SNOMED. Correct. Because the word that you tell should be understood by all the 180 countries across the world. Got it?
Okay.
Whatever you do, please think of ICD-11, SNOMED, HL7, FHIR, DICOM, standard. Okay.
Okay, sir.
Right
Thank
from
you so much.
Yeah, that's it. Very simple.
Thank you.
Good evening, sir.
Yeah, please.
Good evening, sir. Myself, Dr. Yuvraj.
Yeah.
From VSB Engineering College, Karur, Tamil Nadu.
Naladu. Please continue.
Sir, technology is advancing rapidly, but the integration with the doctors and hospital is not meeting the expectations. Researchers and doctors are not well connected, I believe.
Correct.
And the reason behind this could be money or lack of awareness or absence of a poor platform to share the technology integration. Which is what is your opinion, sir?
Good. Your good name, please.
Dr. Yuvraj from Tamil Nadu.
Okay, Dr. Yuvraj. Fundamentally,
Yes, sir.
we have a very poor doctor-patient ratio, unlike in other advanced countries. In advanced countries, doctors have time to do research. Okay. Whereas in India, every doctor has to need a lot of, I mean, is some more service oriented than research oriented. Are you getting the point?
Yes, sir. Yes, sir.
That is the problem. We have to have more number of doctors so that a very good healthy patient doctor ratio comes. Then doctor can turn a little bit and check, oh, what you are doing. Can we join together and do some research? I have wonderful ideas. So now doctor is fully compact with the service. I mean, a lot of patients are there to do the service. And it is a attitude also. That's another thing. Got it? Third thing is that nowhere we have interaction with the doctors right from the study, which means all biomedical engineers, all electronics engineers, all computer science engineers have to have interaction with the doctors community also, which means there must be a platform. Unfortunately, we're all isolated as an industry, as an university. Anna University, Technical University is different. Agriculture University is different. Then veterinary university is different. Medical university is different. We have no connections. But this boundary has to be broken first. That's what has come out very nicely in NEP. You have to have everything under one umbrella so that anybody can interact with anybody without any hassle. So that is a solution.
Okay, sir. Thank you. Is
It's
it
an
possible
administrative
to happen? Is it possible to happen in a short period of time, near future?
Yeah, it is a mindset. If all the academia, if in every meeting we keep telling that yes, there should be no restriction among all the universities, no bureaucracy, no, I mean, government can have control over us. That's excellent. But what is needed is academically, you should be able to interact without any hassle. Got it?
Okay, sir. Okay.
But today, if you want to work with, say, for example, KMC or MMC, I have to write a letter. It has to go through so many channels.
Yes.
That administrative we have to be broken. And if a doctor says, I want to do something, the next minute he has to have the engineer with him, others with him, so that no time will be wasted.
Okay, sir.
It's an administrative decision, that's all, nothing more than that. And the intent to do it. And I'm certain, I'm sure government is taking a right step. Every year they conduct a medical and a lot of other things are there. Digital health conferences are being done. I think government is also very serious. It's a question of time that I think everything will fall in line. Thank you. Any other question?
Thank you, sir.
I have
Thank you
one
very
question.
Please.
I'm Shanta
Yeah.
from Epco Engineering College, Sivaghachi.
Yes, Shanta madam,
Sir,
please.
From CDAC, whether we can get a data, digital data?
Yeah,
Because
that is the problem.
research mostly for freely available.
No. It's like Shanta madam.
Yes,
I've been working on this.
Yes.
We have data. See, I have checked with the government of Tamil Nadu. We have 28 hospitals. They are willing. The only thing is there's a law to see that the patient rights are not violated. What we have to say is, what we have to say is, there's a software for this internationally. What the software will do is, it will remove the name. It will remove the name. It's called de-anonymization. It will remove the name and that the data will be available for the public at a cost, if not. It is possible, but the only thing we have to sit and take a decision. Otherwise, there is no research.
Because normally, while I do my research, I mostly depends on PhysioNet.
Correct. No. How long we can keep depending on others and
are freely available, but in my mind, I have a dot like we are doing research only for other country people, not
correct. You are perfectly correct.
So,
and also, your research will not match with ours because our demography is different.
Yeah, that's what. So if senior like you people can sit and work with somebody else, if we are able to create a database like Physionet, which may
We are
be
working, madam. Santa madam, we are working. We are discussing and we are trying to break. And
okay, thank you.
see, individually people are agreeing. But how
Because
to do it, they are only pondering. That's all.
analytically, we people are really skilled.
Agreed.
So if that that wall is
Yeah.
broken, India will.
Correct.
Yeah.
You are true.
Thank you.
You are true.
Yeah.
Correct. Wonderful, wonderful, wonderful.
Thank you, sir. Thank you.
Yes.
Yeah. Good evening, sir. Yeah.
Yes, please. Introduce yourself.
Yeah, I am Dr. Padmanabh Reddy.
Yeah.
Ananta Padmanabh Reddy, Associate Professor, working as Associate Professor in AIML, Chaitanya Bharati Institute of Technology, Hyderabad.
Hyderabad. Cheppandi.
Sir, actually, it's a fundamental doubt because the students wants to even see, I want the main objective of joining this workshop. I want to motivate the students to take some UG projects. UG projects. Always students were using some 500 or 1,000 or 5,000 tuples which are in Kaggle or some time. So they came up with they really wants to work in healthcare with real data.
Correct.
So as from your session, I came to know some like feedback, some platforms or some things. So so to start up with that, for example, UG projects in the final year or minor project, 6 months to 1 year duration will be there. UG projects. And we should be, as a mentor or as a supervisor, we should be clear about that. So, can you show or can you guide some light on this process? How do we can nurture UG projects in healthcare, like as per their duration and all? So, like we want to give some statements and we want to guide them with some proper data. We can't say in the Google it is like in the Kaggle it is there. Always students will come with the Kaggle data. I have 1,000 tuples. I have 5,000 tuples. Are like that. So some information I got from this. Actually, you said some CDAC people are doing good and they're maintaining like that. Some in this way, if we are and which disease are first initially. If I am assume that I am a new what we'll call novice, new researcher coming into this field. So if I am for example, in the month of December, if I am at least 1 month or 2 months, if I explore and I am very clear, these are the statements, these are the data sets, then I can tune up my UG students. You work this like this.
Yeah.
So
good. Let me throw some light on that.
Yes.
Currently, the NBA in the recent revision of NBA norms and the NEP, they are telling about capstone project.
What's the capstone?
Capstone, capstone project.
Yeah.
Capstone project, where they say that you have to be well qualified to do a good project at the final year, correct? So the qualifications start at the 3rd semester itself. I have given this lecture, correct? So if somebody wants to work in a particular area, he has to be incubated at the 3rd year. Something has to be, his skill has to be developed, like how to write a program, what are the standards involved, what are the materials required, what materials are available here, what materials are available there. And then you were signing an MOU with a clinician, with a doctor or with a hospital, and protecting the rights of the patient. All these things should happen well ahead. That is, the faculty has to take that initiation. So he has to be trained slowly. If it's a hardware, the training is different. If it's a software, training is different. If software in healthcare, it's a different. Software in imaging processing is different. Computer vision is different. Like that, you have to provide that ambience in the college itself, right from the 3rd semester. So when it comes to the 7th semester, you would have got all background. Then also, then one more thing, what you have to do is, if he's trying to work in healthcare, slowly what you do is, either you approach a doctor or a clinician and tell that I want data without the names, etc. Convince him, or all of us should try to meet our higher officials, government officials, from Ministry of Health. And we have to impress that we have Director of Medical Education. We have to impress upon them that there is a huge research potential available in Andhra Pradesh, available in Orissa, available in Delhi, available in every corner of India. People are there ready to do. Why don't you spare with this data? Please do something. It is possible. So everybody has to meet. See, the problem is we are sitting and want everything to happen.
Yeah.
We have to get up, meet people. I'll tell that there will be a lot of resistance, but if you go move 10 times, people cannot resist you. If not this year, next year it will be accepted. Okay?
Yeah. Process
Please.
should be inspected.
Yeah.
Sure,
Yeah.
sir.
Thanks
for your input, sir.
Yeah, that's all. That's all. And for all the participants, I am available at your beck and call. You can call me anytime. And Madam Sachdeva, Madam Shelly, Madam, and Vaithiyanathan has my number, has my email. You just contact me. Absolutely no problem.
Sure, sir. Initially, we are in the starting stage. Surely we will.
Yeah. Please come on Google Drive, Google Meet, along with your student. You check with me. You ask some few doubts. I'm free. I'm for you. Don't worry.
Thank you, sir. Thank you for your assurance and support.
Yes.
And
Yes. Don't worry. Don't feel shy.
Sure. Thank you.
Yeah, most welcome.
Professor, good evening.
Yeah, please. Good evening.
Dr. Sendil Kumar from Vaithiyanathan University, Chennai, Professor.
Oh,
I am one of your student, Rajadosha students.
Okay.
Professor, I have a doubt about nowadays the Apple Watch giving ECG waveform. They are telling about 95% accuracy we are producing. At least in ECG, we studied means lead 1, lead 2, lead 3 system is wanted to measure the accuracy in ECG. Okay. How they included this technology in Apple Watches?
No, it's it is a capacitive type of ECG. Normally, there are two ways of collecting ECG. One is our lead system. Okay, dual lead system. You can go for lead 1, lead 2, lead 3, AVR, AVL, AVF for augmented. V1, V2, V3 chest leads. Or sometimes they even go for the wristwatch. No, it's capacitively coupled. So there also you can pick it up. So almost all such digital wristwatches, etc., the concept of picking ECG is a little different, but however it is successful, people are able to demonstrate. But the only thing is, see, you have 12 types of ECGs giving 12 types of information. Am I correct?
Yes, Professor. Yes, Professor.
See, AVR, AVL, AVF for 3 dimensions. Similarly, V1, V2 gives a lot of other information. So a comprehensive information can be got from all the 12 leads, but wristwatches, sometimes they check only the heart rate. A comprehensive data may not be available. You got it?
Yes, Professor. But they are telling is 95% accuracy like that.
Accurate in, see, let me tell you. For example, if you take an ECG, what data you can get from an ECG? Yeah, I think somebody.
Waveforms.
No. Waveforms in the sense, ECG can give arrhythmias.
Yes.
There are 30 types of arrhythmias. I think using wristwatch, it may be a question.
Yes. That's why I'm asking, Professor.
See,
the medical person, they believe that data are.
No. See, what they say is they have certain objectives. Say, for example, heart rate. With the heart rate, you can say the tachycardia or bradycardia. I think some of them can switch off their mic. There's a feedback.
Okay.
There's a feedback. Dear participants.
Request to kindly mute. Humble request to the participants.
Yeah. Beauty as a child is speaking very nicely, like my granddaughter. Yeah, please switch off your mic, please. Only one who questions can switch it on. Yeah.
Professor, Professor, another one doubt, Professor. If we have some heart problem, taking MRI or CT scan, some of the pointed place is not accurate in that particular heart or MRI or CT scan. How to eradicate that particular dark place in image processing technologies? Advanced level is there or not?
No, no, see, you see, decision, see, let me tell you, some 50 years ago, decision making was made with only 5 inputs. Okay. Man can handle not more than 6 or 7 inputs. It's very difficult. That's what is stated. Any doctor can take a good decision based on only 5 or 6 parameters without the help of machine. Correct.
Yes, yes.
Just because we have machine and wonderful technology like AI, deep learning, today we are thinking of 100 different variables. So to take a better decision, let us not depend on 2 or 3 variables. Sometimes CT scan, sometimes MRI. You have to take very many factors, very many dimensions of data, correlate them properly. I think then you will not miss.
Okay. Thank you.
Exclusively one domain. That's why we say that the fusion of 2 images, correct?
Yes, Professor.
PET
Fusion of
image
2
and
images.
this can be fused in the fusion of images, which means now machine can take better decisions because you can give a lot of inputs, you can train it, it will check so many factors, so many variables, so that the possibility of misinterpretation is less. Missing is less.
If you're using AI in that platform, means it will eradicate all the image.
After all, what is AI? AI is nothing but huge data.
Okay.
You train, you give huge data, multi-dimensional data, multivariable data, with a lot of, I think then you'll be able to take a better decision. Okay.
Okay. Thank you very much.
Just like my dear friends, is like just like this. Imagine a king having 100 advisors.
Okay.
He can take a better decision, correct?
Yes. Thank you.
Okay.
If nowadays AI is incorporated in that image processing process.
Yeah, it's called imaging informatics.
Okay. Thank you.
That field is called imaging informatics.
Thank you. Thank you.
Yeah.
Thank you.
Sir, very good evening, sir.
Yeah, good evening.
Sir, myself, Dr. Kiran Bala from K. Ramakrishna College of Engineering, Trichy, sir.
Okay, please.
Yes, sir. Sir, I am basically from the Department of AI, sir.
Good.
Yes, sir. Sir, actually, what we are focusing, sir, in veterinary science, sir.
Yeah, good.
Because that is we are focusing on 2 categories. One is for ecosystem, another is spreading diseases to human.
Okay.
But the thing is, sir, the veterinary we are not having so much of data and so not having so much of awareness of incorporating the things, sir. So that is a problem because whatever the disease coming, maximum the disease may be spread from the spreading disease, means it is from the animals.
Yeah.
So, but we are not cautious about those kind of things. So it is a prevention of act. So we are focusing on the how after the diseases occurred. So how to prevent the diseases? What are the ecosystems has been damaged? So we can able to satisfy those things, but we are not having the data and we are not having accurate things. So how to stabilize these things?
No, obviously this comes under a heading called public informatics. Okay.
Okay, sir.
I hope you remember under under health informatics, there is a subdomain called the public health informatics. Public health informatics focuses on surveillance, which means you have to get inputs from all sources. Suppose you want to check whether a particular disease is spreading, and what methodology, where it's spreading, what is the role and the inputs. So which means data collection is fundamental. Sources of data is fundamental. Unless you have a very good source of data shared by the stakeholders, we are just sitting ducks. We cannot do anything. You are wonderful. You have all the facilities. Technologically, you are good. But without data, and that too, dear participants, what I would like to impress upon you is that with only 10 data, 20 data, we are doing research. We need thousands of data, which means, yes, a system has to be developed. The data has to be shared. There is the answer for all is the research in India. We beat AI, mining. See, we're all using AI, deep learning, my words, but without data, all these are meaningless. Only we are learning without application. Unless the barrier is broken, the data is made available. And fortunately, India has 100 times higher data than the world. Only thing, India has to have the intent to share this data with wonderful research like you and me, researchers like you and me. Okay.
Yes, sir. Yes, sir.
Oh, there's a wall. Us. We have to pray God. We have to do something to break it.
Yes,
Okay.
Sir, sure, sir. Yes, sir.
I think I have another topic. After that, you can ask questions.
Yes, sir. Yes, sir. Please.
Okay,
Yeah,
okay, sir.
We'll
no,
this first session is health informatics impact and way forward. Second is AI in dentistry. There I will talk about AI also. Can I go to the next topic?
Yes, please, Professor. Please proceed.
Yeah, thank you. I'll close this. Is the screen visible?
Not,
Hello,
sir.
is this
Not
Not
No.
yet, sir.
No, sir. No, sir.
okay?
Not visible, sir. Share. Now,
Yes, now visible.
is it visible?
Visible, sir. Visible.
Yes, sir.
Ah,
Yes,
good. Thank
Professor,
you.
yes.
Thank you then. I'll go to the topic. I'll go to slideshow. Okay. So the future of dentistry. I mean, every field needs AI. Even literature needs AI. Poetry needs AI. Everything needs AI, deep learning, everything. So no doubt dentistry also needs AI under digital health. AI in dentistry. I just want to recheck. Is my slide visible?
No, Professor, slide is
No,
not
sir.
visible. Your screen is visible.
Audio is coming. Okay. You are sharing
Your
your
slide
video.
Your screen is coming, but your slides are not visible.
Okay. I'll do one thing. I will stop sharing. I'll close it and come back. Okay. Now is the screen visible?
Yes, sir.
now visible,
Okay.
sir.
Visible.
Good.
Yes.
Presentation mode you can select. Right?
Yeah, I'll go there. Now slideshow. Is the slide moving?
Yes,
Yes,
sir.
sir.
The third slide, AI in dentistry heading.
Yes, sir. Yes, sir.
Yes.
Good. Good. AI in dentistry. Good. Now for a change, I'll put some video on AI and dentistry. Okay. All of you can sit, relax, and listen to this 10 minutes video. Is the video audible?
No, sir.
Not audible, sir.
No, sir.
Not audible.
Not audible. Not audible.
It's a YouTube. So one thing then. Should be audible. Is it not audible?
No, sir. No
Not audible.
audibility, sir. Only video is shown.
Video is coming. It says I've given the link as video only.
Yes, sir.
Yeah, sorry to interrupt you, sir. Actually, there is one option for including the audio of this particular meeting
Yeah, please
presentation.
tell me.
So you can see it on the tab where right top of the tab, there is one option of include video. Just
Where is
click
it?
on that and then the audio will come. Not in presentation, sir, in the meeting, in Teams.
In Teams, I'll go there.
Yeah.
Okay.
So there
Chat,
is one option of include audio.
I'm unable to see. You have chat, people, raise, react,
Stop
view.
sharing, sir, once. Stop sharing once.
I have to stop sharing.
Yes, stop sharing and share it again, including the video, including audio, sorry.
Okay, I'll stop sharing. I'll go back to sharing.
Share, and there you can see the include audio option while sharing.
1 minute. Presentation content only, stand out, side by, reporter. Include audio.
Yes, please check
It's
on
on
that.
now. Yeah, it's on now. Correct.
Now
then
you
I'll
can
go for
share it.
sharing.
Yes, sir.
Okay, good. Let's check up. Is the video is, the screen is moving?
Yes, yes, sir.
Now please tell me.
Now audio is coming.
Now
Sir.
audio.
Okay, enjoy.
Thank you.
Thank you.
Hi, my name is Rob Koltz, and I'm the clinical director with Overjet and a practicing dentist. And I'm really excited today to be able to talk to you about artificial intelligence and its impact and how it's transforming dental care. Now, artificial intelligence is something that we're all impacted by an immense amount through our interactions through companies like Netflix, Facebook, Google, Tesla. The amount of our interactions with artificial intelligence is much more significant than we realize. Now, in healthcare and specifically dentistry, the impact can even be more life-changing. I'd like today to talk about 3 areas where artificial intelligence is really impacting dentistry and how it's going to really change how you deliver dental care in your practices. So the first one I'd like to talk about is standardization. What I mean by standardization is how doctors and clinicians can have a uniform set of objective measurements that they use when delivering dental care. The second area in which artificial intelligence is impacting our delivery of dental care is through improving our diagnosis. So not just standardizing it, but making us more confident and competent in our diagnosis. And the third aspect I'd like to talk about today is how artificial intelligence can really increase and improve the case acceptance that we experience as we have conversations with our patients. So I'd like to start with a story. And this story is not my own personal story, but it is a true story. And it's the story of a young lady who had been going to a dentist for a number of years and had your usual restorative treatment plans. A couple of fillings, every few appointments, nothing major. But then to a change of insurance and life circumstances, she was forced to go to another dentist at her next visit. And when she went to that dentist, she got a treatment plan that surprised her with 7 or 8 different cavities diagnosed. And the question she had was, why didn't my last dentist see these? Or why did my new dentist see these? And which one is right? Was one dentist underdiagnosing? Was the other dentist overdiagnosing? And really the question was, how can she as a patient make a decision and know which dentist was providing the more accurate or more appropriate treatment plan? And the reality is either one of those dentists could have had an appropriate treatment plan, but how was she as a patient supposed to know? That patient's name is Vaithiyanathan, and she would go on to found and be the CEO of Overjet, which is the largest provider of artificial intelligence services in dentistry in the United States. Now, not all of our patients have the ability to go on to found an AI company to help provide standardization and clarity on their treatment planning issues. But all of our patients face similar questions. Now, let's take that story and let's apply this to a more scientific experiment. What you're seeing in front of you now is an image that was shown to 75 licensed dentists. Now, they were seeing the image without those blue boxes labeled. The blue boxes were added later by Overjet's AI services, which labeled caries on the x-ray. And we asked those 75 dentists to take that raw x-ray and within the computer software that they were given to place a blue box around caries, primary caries, excuse me, and place a yellow box around secondary or recurrent caries. And as you can see, the results of that are that every single tooth and almost every single surface was diagnosed by at least one dentist as requiring treatment. Now, this is the impact and the experience that our patients are having daily as they come into our offices. And so the question is, how are they, without having any prior dental education, supposed to know which treatment plan and which doctor they can trust and which is the most accurate treatment plan that they're receiving? Now, I want to take this as experiment and I want to take this a step farther. And I want to give to you this hypothetical example. So let's say you're sitting in your office and your hygienist comes in after taking x-rays on a new patient. And she says that she's got Bob Smith in the chair and that Mr. Smith has generalized 4 and 5 millimeter pockets on the right quadrants and moderate bleeding on probing. I want you to think for a moment, with that diagnostic criteria, what is your treatment plan? What is the first thing that comes to your mind? And obviously we only have a small sample of information, but often this is what we're given as we're sitting there in our office and needing to make these decisions. So for most clinicians and most hygienists and doctors, you start thinking scaling and root planing. You start thinking with this sort of clinical criteria, I must need scaling and root planing. So now let's add in a little bit more information. Let's add in an x-ray. So what we see here is a bite wing that's been overlaid with Overjet's AI findings on top of it. Now, let's think about the diagnostic criteria for scaling and root planing. Dental insurance companies, for example, and this is following, for the most part, the AAP, the American Academy of Periodontology's guidelines, require 2 things in order to accept and approve payment for scaling and root planing. First of all, they require that there's some sign of an inflammatory process, and that's measured by your hygienist through her periodontal charting. And the second thing that almost every dental insurance requires is signs of radiographic bone loss. Now, what you're seeing on this x-ray is bone level measurements that Overjet has automatically calculated on this x-ray, measuring from CEJ to the crestal bone. And so what we have here isn't bone loss necessarily, but this is a bone level measurement. And how do we determine when it becomes bone loss? Well, for that, we have to go to the literature. And we know by looking at the literature that no evidence of radiographic bone loss, or what we would call biological normality, is 0.4 to 1.9 millimeters from the CEJ to the crestal bone. So in this instance, do we meet the criteria? Do we have radiographic bone loss and do we have inflammatory process? And the answer to that would likely be no. We have periodontal probing depths, but there's really no bone loss on the x-ray. So is scaling and root planing in this particular case an appropriate treatment plan? So now I want to take a step back and let's talk about what we just did there. That process that we just went through is called standardization. So we created a set of criteria based off probing depths and bone level measurements that we can use to apply standardized uniform principles to diagnosis on our patients. So now as you go through this process, and you can do this on a number of different procedures, you can do this on caries detection and size of lesions through the enamel, assisted by artificial intelligence to help you more accurately quantify where those are on the teeth. And if you think about going through this process with your hygienist and creating criteria for probing depths and bone level measurements that in your practice would equate to a patient needing scaling and root planing, think of how much more of an experience and better experience your hygienist and more importantly, your patients are having by having a standardized process. So that's the first area in which artificial intelligence can really help improve your practice. The second area is on your diagnosis. And now when I say diagnosis with artificial intelligence, we're not talking about the quantity of the diagnosis, we're talking about the quality of the diagnosis. So if we look at in dentistry, how much restorative and periodontal treatment goes undiagnosed, the amount is significant. Now, most patients would think, if you surveyed them, that there's an overdiagnosis problem in dental practices, that they go in and they get diagnosed with more procedures than they actually need. But the reality is, if we look at the x-rays and we look at the literature, underdiagnosis is a much larger problem. In fact, 28% of restorative treatment goes undiagnosed, and almost 2/3, 60% of periodontal disease goes undiagnosed. So how can artificial intelligence help with our diagnosis? How can it help us more appropriately and adequately diagnose our patients? For that, let's look at a couple of x-rays. So this is an example of bite wing x-rays, of course, and I want you just to take a moment and look at it and identify in your mind things that jump out to you. Maybe it's the quantity of the subgingival calculus, maybe it's the caries on the mesial 3, distal on 4, something certainly going on the mesial number 19. And as you're going through this process, this is what you were trained in dental school to do. You were trained to look at black and white x-rays, identify areas of disease, and then mark them for treatment. Now, I want you to think about how adding artificial intelligence analysis on top of that x-ray impacts your ability to detect decay. Now, this was not necessarily a fair experiment because you were looking at it through this sort of webinar-based environment, and in your own monitor, you'd be able to adjust the hue and the saturation and enlarge things. But walking into a treatment room with the AI findings overlaid on top of the x-rays and turning them on and off and comparing, we found that doctors on average will diagnose about 22% more restorative procedures than doctors who don't use an artificial intelligence software. And again, the goal of AI is not to get you to diagnose more, but it is to get you to diagnose more accurately and more confidently. And so by using artificial intelligence, we can help augment our process and help ensure that we're not missing things that sometimes during maybe a hurried exam at the end of the day, or you're busy in your other chair and you don't necessarily mean to miss these things on the x-ray, but sometimes we do. And artificial intelligence can help us minimize our amount of disease that we're missing on these x-rays. And the third thing I'd like to talk about how artificial intelligence can help us in our dental practices is through case acceptance. So case acceptance in dentistry, unfortunately, is very low. So on an established patient who has a relationship with you, on average, about 52% is the nationwide case acceptance level from an established patient. And the number, of course, goes down significantly on a new patient. Now, think about why that is. Why do only 30% of the treatment that we diagnose, why does only 30% get accepted by new patients? A lot of people think it's because of cost, that it's a financial burden. Now, finances certainly plays a role in that process, but the reality is that the number one reason that patients don't accept treatment is a lack of trust in their providers. They don't trust that the treatment plan is in their best interest. They don't trust that the accurate and adequate diagnosis was made. That's the number one reason. And so how can artificial intelligence help with that issue? For that, let's look at another set of x-rays. Now, this set of bite wings was actually sent to me by a DSO with the complaint that the patient was upset and complained about the number of cavities that had been diagnosed by the provider. And they wanted to see if an artificial intelligence platform like Overjet could help in that process. And so as you're looking at this x-ray, there's not a lot of major things that jump out at you. There's a couple areas of interproximal decay. But think of this from a patient standpoint. This is what your patient is being exposed to. What information does your patient glean from these x-rays? The answer is almost none, right? So a lot of doctors, and myself included many times, won't even show x-rays to their patients because the amount of information the patient gets is really insignificant. And an intraoral photo, for example, typically would become the new gold standard. Well, now what if you could show your patient this set of x-rays with artificial intelligence findings overlaid on top of those x-rays? How much more significant and how much more of a story does this give your patients than the unannotated images? Now, your patient isn't a doctor, of course. They may not understand necessarily what they're seeing. They may not recognize what the treatment recommended is going to be by looking at these x-rays. But when they see this area with areas of yellow, meaning incipient caries, and areas of red, meaning caries through the enamel, they recognize that there's going to be some sort of conversation, that something is present on these x-rays, that when the doctor comes and talks to them about these x-rays, there will be a less surprise at the treatment plan that's given them. And it acts as a second set of eyes for them. So they have this unbiased, objective observer who can help them look at these x-rays. So these are the three areas where artificial intelligence is really poised to help you in your practices. Number one being standardization among your clinical providers. Number two being improving your diagnosis. And number three, increasing the case acceptance in your practice. Thank you.
Hello. Hello, am I audible?
Yes, sir.
Yes, sir.
Good.
Yes, sir. You are audible, sir. Please.
Was the video clear?
Yes,
You're able to
sir.
listen?
Yes, sir.
Yes, sir.
Yes.
Good. What is the
Yes, sir.
takeaway?
Clear.
What is the takeaway? After listening to 12 minutes, what's your conclusion? Yes, please. Okay, can I tell?
Yeah. Yes, sir.
Yeah, I'll tell, then you can join with me. Don't worry. First, in dentistry, have you heard about insurance?
Yes.
Medical insurance,
Yes,
Mediclaim?
sir. Yes, sir.
Yes, sir.
Good, good. Unfortunately, there is no Mediclaim for dentistry. Got it? The reason is mistrust. That's what that also he is telling. He told about a lady who was very good in AI. She went to a dentist. He diagnosed something. Another person diagnosed something else. Another person diagnosed something else. There was overdiagnosis. There was underdiagnosis. Therefore, completely, there's a possibility that the public may lose faith in the process of dentistry. That's what he was trying to explain. Not because of the doctors are incompetent, for various reasons. It's very difficult also technically. Okay, let us take that, leave at that point. Fundamentally, what he's trying to say is diagnosis is not proper. In fact, the advantage of AI, he says, he had 3 levels. What are they? First is, what are the three layers is? What is the first one?
Convolution layer.
No, he's talking about standardization. You got the word?
Yes, yes.
Right now, the problem comes, the mistrust comes because of non-standardization. You got it? There's a beautiful world in medical, that is evidence-based medicine. Evidence-based medicine, which means you have to show evidence. It cannot be arbitrary. So in dentistry, with the AI, you can create evidence. There may be some flaws in the human system. You cannot blame individuals. They may not do it with their intention. It may be difficult to diagnose. In such cases, what is expected is standardize your diagnosis process so that whether I go to X or whether I go to Y or whether I go to Z, whatever be the level of competency, if you take the help of AI, yes, the decision making would be fine. That's what he said. The decision making would be fine. Therefore, there will be a standard diagnosis process because of the help of AI in dentistry, number 1. Because of this standardization, because of this perfect, that is neither it is over-diagnosed, nor it is under-diagnosed, perfectly diagnosed, trust improves because you show them the evidence. If the trust improves, naturally, diagnosis improves and treatment plan also improves. You have better treatment plan because you know how many tooth has to go to our root canal treatment, how many has to be removed. And once these are all very well designed and evidence is created, naturally, India also will be on the list of accounting for medical claims. In USA, it is now accepted because they follow, I mean, what they will do is the insurance people will have their own software. They take an X-ray, I mean, all the X-rays given by the doctors will be given and they give it in AI. AI will decide how many, I mean, root canal treatment has to be given for this particular, how many was claimed by the doctor. If they are in synchronized, then the money will be sanctioned. Whereas in India, it is not so. That is the advantage of AI. So AI does standardization, AI does better diagnosis, therefore acceptance. See, case acceptance is higher. So what a beautiful advantage AI has. So with this introduction, I'll quickly, another 20 minutes, I'll complete my slide.
Sir, can I ask a small question?
Why not? Why not, please?
Sir, this is Dr. Ashish, sir.
Yeah, please.
Sir, isn't there any biases coming up? You
Yeah,
just
true.
told in the example 3 to 4 options. Then it's okay. I can understand. Okay, option 1, 2, 3, probability 33% correct. But like when the GPT-4 or something it developed, 10^12, like competing with the human brain, 10^14 calculations or training parameters. Like so there are biases coming up. So how do you decide which one is the right option?
It all depends upon the number of cases you have taken. Initially, training is important, correct? See, a doctor also becomes experienced. How does a doctor become experienced? By going through many patients. Am I correct?
Yes, the correct
So
thing.
you have to train the AI with large amounts of data so that it takes a better decision. Every individual may not have an opportunity to go through, I mean, thousands and thousands of data, but you can give it a machine. So machine can see through all this data, find out the important, I mean, features for decision making. I think it can take a better decision. Not that doctor cannot take. Yeah, please.
One next question, like related question.
Please.
How do you decide which weight is more important? It's 3,000 of data.
No. Again,
In
doctor has to give input.
normal MATLAB part, I build it through MATLAB the matrix of weights for the factors.
Okay.
But when large scale is there, considering
Yes.
multi-dimensional graph become impossible.
Yeah.
So how do you decide the weights?
Again, see, it's a feedback. Okay. See, when you train the network, there are two things. See, always there'll be human intervention. In one case, see, human will decide, okay, these are the features. See, let me tell you again, AI is also NI. Am I correct?
Yes, sir.
AI
is
is
a
also.
big class, having machine learning, then deep learning inside.
But see, even that, it is the man who teaches the learning, correct?
Yes.
So every AI is an NI. See, it comes only from natural intelligence. Suppose you design a computer for a chess. All the moves are taught by human being only. But only thing is, human being may not be able to take all the inputs and take a decision. This is accepted fact. What is said is, a doctor can have 5, 6, 7 parameters for making a decision, whereas a machine can take 100 parameters and take a decision, permutation combinations. That is the only difference, because you can give various situations.
Probability can be included.
Yes, correct. Yes.
Combinatorial probability.
Yeah. And one more thing, my dear friend, there is another thing. Now people are not accepting AI. Correct?
Sir, in the medical data, they are giving anything. They're training the data, publishing in high impact. But worthless data, sir. Worthless data.
No, let me tell you one thing. The dental forum of the World Dental Forum, they had a meeting. What they decided was, it is not, they say AUI, augmented intelligence, which means artificial intelligence plus human intervention. So then only they take a better decision. So purely you give to a machine, it is not acceptable. That's why slowly the word AI is replaced by AUI.
AUI.
In clinical area, they don't say AI-based decision making. They say AUI-based decision making, because machine takes a decision, human also gives the input, and finally decision is taken.
Awesome, super. This is the new term I learned.
Yeah, AUI. And this is decided by the World Dental Forum. You just for your kind information, you put the words dental informatics, AI in dental informatics, AUI, you just put a word. It's a resolution.
So AUI term is applicable every year.
Yeah, no, it's a resolution. Throughout the world, the dental people has to accept only output of an AUI, not AI.
Great, sir. Super.
Yeah.
Thank you so much, sir.
Welcome. Good. So you see the fathers of artificial intelligence, nothing much about it. And this is the history of dentistry. It started with braces, then toothbrush, toothpaste, fluoride, implants, and today we are in digital dentistry. AI is being used. And the artificial intelligence, machine learning, deep learning. And I was given the difference also. And it is how the images are taken. Okay. And normally, this is the machine which does the help. And now I'll really get into the topic. See, this is a simple machine, the X-ray machine, which can take a day. I mean, it can be it's a home care device. And images are cropped, everything is done here. And I now, my dear colleagues and friends, I'll go through all varieties of abnormal images. Just have a look at it. This is a raw image, okay? Then what are you going to do with these images? Because you will find out how many tooth are individually available, where are they available, are the location correct, are the size correct, are the thickness correct, are the color correct, are there any edges, gaps, how much is the distance, what is the gum area? So all this thing is image processing. So, okay, teeth detection, number of teeth, giving numbers to each detection. This is gingiva detection. And tooth numbers are given. See, this is what is your software does. I think we should, our salutations to all those computer science, IT, and other engineers who write programs on this. This is an image given to them. They write wonderful programs. This is the tooth number 1, tooth number 2, tooth number 3. They are in place. They are tilt. They are angled. They are good. They are bad. They are discolored. So many information that you can derive. So tooth number, detected zone, prediction zone. You can see how AI-driven identification, numbering number they give. Okay. Then they find out the gaps. Is it really good or bad? What is the situation? Are there any diseases? See, are there elongated, shortened, angled, tilted? And then this is an instrument. So whenever this is RCT, this is called root canal treatment. Normally we have nerve coming through this, and if your tooth gets decayed, this gets spoiled, they'll remove the natural thing and they'll put so that you will not have any sensation. So they'll check this with the X-ray, and this length is very important, my dear friends. This you see here, there's an instrument that you have to carefully exactly give the ring. If you put less or more, there'll be pressure, you'll get a lot of pain, tooth pain will be there. So the doctor has to measure correctly, and it's very important because it's not visible. It's a very thin substance. So take the help of machine. See, that is where the technology helps the doctors. So this can be measured perfectly. The shape can be measured, the size can be measured, length can be measured, and also the enamel, whether it is eroded or not. So identification of PALs, resolution over time. And you can see panoramic, this is a panoramic X-ray vision. And there are various types. And then dentists are inconsistent. Naturally, we cannot blame them. The field is like that. It's very difficult to do even RCT. See, there are certain surgeries which is very difficult. So you have to appreciate the dentist. You have to thank the dentist. So dentists are inconsistent. Digital dentistry is untapped potential. Yes. See, when there is a lacuna, if a machine can help us, why not we take the help of a machine? Absolutely no problem. See, once we were going to other places using a bullock cart. But do you prefer now? Technology is available. You go by a cycle, you go by a scooter, you go by a car, you go by a flight, you go by a ship. You don't now prefer a bullock cart. So today technology is at your disposal. When the technology can make you take a better decision, why not we take the technology? All the bottlenecks and insufficient can be taken. Dentistry, that too. In dentistry, you have unparalleled potential for use of AI. Let me tell you, my dear friends. And the impact is, once you use the knowledge of AI plus the knowledge of the doctor. So I'm not telling AI, I'm telling AUI. So consistency, trust, health improves. There's a better growth, savings, efficiency, risk reduction. Automated and predictive diagnosis can happen. Treatment planning, because that's trust builds, consistency builds, case acceptance increases. Treatment planning is better because there is a standardized diagnosis process. With all these things, I think in next 5 years, India dental problem also should be solved. And I mean, pray to God is that even dental surgery, dental operation should be given insurance, for which we have to adopt AI quickly. So that's what is happening. So traditional 2-dimensional dental radiograph, and you can see the varieties of types of images, photographs showing 3-dimensional anatomy, premolar, molar, okay, embedded in a bone, without bone, and tissues, white, all these things. I'm just browsing through. So you see, this is for your call the engineers. So when you give to a doctor, the doctor would like to know where is the maximum variation is there, where the minimum variation is there, where is the enamel eroded, how much area is the enamel, is it accessible, not accessible, all these things, and what is the length of this. If I want for the root canal treatment, yeah, computer can make. The brain of again, let me tell you, computer means again your brain. See, let us not say it AI, because AI, your NI is put inside the computer and you call that as AI. It's only your brain, our program, our algorithms. So factors associated with enamel, there are so many defects in enamel, the environmental alterations by birth, their problems may come by inheritance. They come by acquired diseases, inherited diseases, environmental, development diseases. See, enabled because of so many reasons. All this can be studied very well. Then Turner's hypoplasia. So you can see this is the shape of that abnormality. This is the shape of this abnormality. This another abnormality, fluorosis, dental fluorosis. Okay, unequal length. See that upper jaw, the teeth is higher length, lower is less, and the abrasion, attrition, erosion, fraction. These are all varieties of abnormalities. Okay, all these things, you give to a computer, it will help you, it will assist the doctor. Okay, reabsorption, clinical features, radiographic appearance. Then discoloration. Yeah, you can see bacterial stains, iron, tobacco, food, medications, respiratory materials, digital hemorrhage, intrinsic intrinsic reasons for tooth discoloration, extrinsic reasons for tooth discoloration. Then ankylosing, impaction. See, I think I'm only introducing these terms. The development of alterations of teeth. See, you have to identify the number of teeth. Hypodontia in the terms of number of teeth, size, can have microdontia or macrodontia. Based on shape, you have normal, abnormal. Based on structure, morphology, you have normal, abnormal. See, this is what is called hyperdontia. This is what is called hypodontia. See, when you see these things, don't you think you can write wonderful programs? Yeah, that's the passion. Then see, the newborn baby has a teeth. Normally, they may not have it. So neonatal children, and here you can see additional supernumerary teeth is there, and the microdontia, macrodontia, gemination, which means there's a tooth is split here. Here, two tooth are merged together, fusion, whereas a single tooth is split. These are all types of abnormalities. Then concrescence, it looks like a crescent shape, concrescence. Then evaginatus, both in and out. Then hypercementosis, then taurodontism, which taurodontism means the root, you can see enlarged body, enlarged pulp, bigger, the shape has increased, area has increased. Then you have local systemic problems, supernumerary, I think, see, hypomaturization, hypocalcified, these are all imperfections. A lot of imperfections are there. There are imperfections 1 type, 2 type, 3 type. I'm just showing the images, radiographic images, and you can see healthy tooth, tooth with deep caries, enamel problem, then depth of that, pulpitace, periodontitis is a very big area. Right? So I think AI can do wonders here, and the instrument is inserted here. Now today is the knowledge of the dentist who takes the decision correctly. Otherwise, it will be a big problem. See here. If it is this goes inside, you'll be pain. If it is less, you'll have pressure. So it's a perfect decision. Something has to be done. So expertise is needed. I think AI can help people. And NLP, yeah, report writing, natural language processing. You can use NLP, real-time education, robotic surgery, individual care, oral systemic health care. AI. Finally, as seen in the video, what he says is, if you use AI and the support of expertise of a doctor, I'll call that AUI, augmented intelligence. I think your diagnosis process will be standardized. Once your diagnosis process is standardized, your process of treatment plan will be standardized. Once treatment plan is standardized, the insurance people will accept your treatment plan, and whatever cost that you propose for that will be accepted by insurance agent without any mistrust. And from that day, all of us will enjoy the insurance. And the AI for consumer, that's naturally. Daily maintenance, the self-monitoring mobile phones, you can also pick up, you can find out. Okay. So man and machine can join together, do wonders. And I think I have a few more slides. I'll stop here because what I'm trying to give is, it's all about fundamentals. Digital images. What is a digital image? How does a digital image look like? Then is what's a binary image? What is a grayscale image? What's a color image? Okay. Well, just I'll go through, just watch it. So this is a binary image, 0 and 1. This is color scale image, which is 0 to 255 levels. Color image is nothing but RGB. So each pixel has 3 bytes of information, 24 levels there. So when you combine each pixel at the, you can see that there are 640 into 480 into 1. So every pixel here is combined, then you get the true color. So, color is divided into red color, green color, and blue color, RGB. And every point here combines with the true color. So that is how images are developed. So you can see these beautiful images. And as far as image processing is concerned, object classification. Yeah, you can classify objects, all ships, types of, all different types of cars, all different types of trees, all different types of flowers you can classify. That is one advantage of classification. Another is object location. Where is that cat? Yeah, I can identify there's a cat. The question is the location, positional value you can identify. And given 2 or 3 objects, can you identify that object? And also, can you really write a story? You give a scene and you should be able to write a story. Semantic segmentation is possible. You see this wonderful image. A lot of things are there. This is beautifully smiling. Can your AI say whether she's weeping or smiling? Can your AI find out how many teeth is there? You can count, but your program has to count. You see the bicycle wheel. Can you say how many spokes are there? And you see a lot of fruits there. How many grapes are there? First of all, are the grapes available? If grapes are available, how many grapes are there? Count it. And after counting, what is the size of each grape? What is the volume of each grape? What is the intensity of each grape? Are there any pineapple? Where is it? Where is the location? How many are there? So, and do you have a clock in that? Yes, I have a clock. What is the time? I can say it's just 10:10, but your program has to say 10:10. There's a lot of difference. So then you see how to write a program. So you have to, take the image and identify whether the clock is there or not. After the identification clock, identify whether there is a small needle, where the big one, then see the angle. Wonderful is the image processing. And this is what is the RGB. And here, my dear friends, let me quickly, is very important. Please listen. See, you should understand high pass filter, low pass filter, band pass filter concept. See here, you can see if you pass this is the, see, try to see the image digitized. This is an analog image, but to look, it may look like a car, but for a computer science engineer, it looks numbers. So this is 69, this is 60, this is 69, this corner is 179. Like that you have to show. That is what is digital knowledge. This analog knowledge is the digital knowledge. When you look at this, car will not be visible. When you look at this, number will not be visible, but you have to learn to live with both of them. So you can see 69 is becoming 100. So there's a difference of 31. So here is a big gap, threshold. Then you say, this is a line. There is a boundary here. And because you can see this side is white, that side is white, then in between you have a black. So you are moving from black to white. So black is 69, 68, 70, 68, 64, 58. When you move to white, it's 100. So you can identify this is the boundary. So this so you can identify. Suppose if you give this a low pass filter means what? Low values it will pass, which means if you say all the values more than 80, less than 80 should be passed, means this will be passed, this will be passed, this will be passed, this will be passed. Whereas this value will not be passed. That is outcome of the low pass filter. If you say high pass filter, you say that all the values above 100 will be passed. Then all these four columns 1, 2, 3, 4 will not be passed. Whereas the columns 4, 5, 6, 7, 8, 9 will be passed because the values are more than 100. So this is a concept of high pass filter. If you want band pass filter, say that all the intensity values between 60 to 100 should be passed. Only they will be passed. And that same concept is shown here in another image. And I'm coming to that. They're general images. This is a medical image. Okay, pre-processing. These are all noise and salt and pepper noise. Median filter is good. Okay, and you can use smoothing, sharpening, a lot of algorithms. I think it's time. Let me stop here, and we'll go for questioning. And this we can learn anytime, or sometime else we can meet. If what I want to say is, if you want to learn about image processing, I think I have wonderful material. I can show you convolution, types of AI networks, Alex, all those things, how they operate. How do you really use the right programs for deep learning, machine learning, all those things. I have the material, but okay, fine. There is, something has to end somewhere. Today, let me call it a day. And I'll interact with you for next 5 minutes. Then we'll have a rest. Yeah.
Thank you, Professor. Participants, quickly, if you have any queries, please come forward. One by one, please. Participants,
Hello,
queries.
Sir,
Yes.
good evening. Sir, good evening. Thank you for your presentation. Once again, I am Shanta from EBCO, sir. So if we create any mobile app or website app, app for any application, like even we can take for ECG, if we want to know the arrhythmias in addition to heart rate, we can create a mobile app.
Correct.
But a similar, we can create a website, then it will become one product, right?
Correct.
What are all the standards we have to follow? We have to check whether our software has.
Same thing. I said no. I think I have shared this being recorded. You please refer. I said software standard, hardware standards. Do you remember
Yes,
the three important
yes,
slides?
yes. Software, software. Already you told software standard and hardware standard.
Always.
Yeah, that's what I'm asking for
yes,
mobile
yes.
app. If the,
No, it's not mobile or it's a software. See, I'll tell you, my dear madam, it's like this. Software can be standalone software, means 100% software. Got it?
Yes. Yes, yes.
100%. Everything is software, no hardware.
Software.
Got it?
Yes.
Even there, your 62304 has to be adhered, standard. Okay?
Okay.
Sometimes you may embed a software inside a microcontroller chip. You can write a microcontroller program.
SOC like.
Even that is a software. Suppose you are writing an ECG, correct? You are using a microcontroller to acquire data, to process data, to give the result. That also has to go through 62304 standard. That is whether the software is 100% software, 80%, or 30%, or inside a chip, outside, doesn't matter. Software is a software.
Yes. Okay, sir. Thank you.
Okay.
Hello, sir.
Yeah, please.
Sir, your presentation is very nice.
Thank you.
Sir, I have one question, sir. For dentures, we are obviously using biomaterials for implantation.
Yeah.
In what way these techniques can be used in those areas, sir? Use any?
I'm not getting. What's your question, please?
Sir, we are using biomaterials for dentures. Yeah.
Okay.
In what way? In what way this AI and these things will aid the engineers, that is biomaterial engineers, to
good.
To design a perfect dentures model.
No. Okay, I get you. See, the idea is very simple. Okay. Are you able to see the slide?
Yes, sir. Yes, sir. I'm purely from biomedical.
No, that's fine. Right? I'll show you one thing. Take for example this one. This is a material that is actually inserted. It's called an instrument. Okay. In RCT, root cavity treatment, they remove the natural and put the artificial. This is an artificial material. Okay.
Yes, sir.
This artificial material first to satisfy the biocompatibility standard. I told you. Okay, number one. Number two, as you said, how does it help? This is an X-ray image. AI can help whether the placement of this instrument is proper or not. Is there any gap left out? Is it protruding additionally outside, which will create irritation? Or is it sort of, it has not gone to, there's a very little gap, 1 to 3 millimeter gap. Is it acceptable or not? So all these things AI can help, which is restoration. And also you see an enamel. Okay. Filling will be there. Am I correct? Are you getting the point? You will have some gaps in the tooth, and I think it will give a lot of pain, and we'll go to the doctor. They'll fill it up with a material. Correct?
Yes, sir. Yes, sir.
After filling, has it been filled properly? Is it overfilled or underfilled? Even after filling, is there any gap? All those analysis can be done using a program.
Now I am getting. Okay.
Very good. Good.
Thank you, sir. Thank you.
Welcome. Hope everybody enjoyed.
Yes, Professor. Thank you so much.
Enjoyed, sir.
Most welcome. If I have been of some
Thank you
help
for
to
your
you today.
great presentation, sir.
Nice.
Thank you, Professor. Thank you. Thanks a lot.
Best wishes to all the participants. Daily listen something, because listening is very important. Learn. Learning through listening. That's why God has given us 2 years. Please listen more. Madam.
Thank you, Professor. Thank you, Professor.
Okay.
Yes, sir. Yes, Professor. Yes. Thank you, sir. I'll keep in touch, and other things we'll do, sir. Thank you, sir.
Sure.
Thank
Welcome. Bye then. All the madams.
Professor, good night. Thank you so much, Professor.
Thank you, ma. Thank you very much. God bless you all.
Thank you, sir.
Okay, sir.
Thank you all.
Thank you, sir.
Tomorrow we'll meet again at 6 o'clock. Okay, tomorrow session start at 6
And
o'clock.
only one request is, don't feel shy to contact me.
Sir,
Okay.
sir, so a small question, sir.
Yeah,
Sir?
please,
Sir,
please
you
go
said
ahead.
that you are taking the attendance through Teams at 6:45 and 8:45. But sometimes
Yes.
if you are continuing attending any
Professor, you can
network
leave, Professor.
trouble,
This is
it
query
will
with
be
us,
left
actually.
come.
Internet related.
Okay,
Yes, sir.
okay,
Sir,
sir.
this is
Thanks.
related to the coordinators. Sir, in case you would like to leave, you may leave, please.
Yeah.
Leave, sir.
Thank you, sir.
Okay.
Okay,
Thank you,
sir.
Professor.
Thank
Thank you. Good night.
Bye bye. I'm leaving.
Good night, sir.
I am signing off.
Yes, sir. Yes, sir.
Thank you.
Okay.
Thank you.
Yes. So I
Participants, now
already
you can put your queries.
I already announced at the starting of the session that we'll be taking attendance for the session 1 at 6:45 and we'll be taking the attendance for session 2 at 8:45. So we already downloaded